Hi. Good morning. My name is Manon Choinière. I am a professor at the Department of Anesthesiology and Pain Medicine at the Université de Montréal, and I'm a full-time clinical scientist and at the Research Center of the Centre Hospitalier de l'Université de Montréal. And and first, I want to thank the Pain BC for having organized this webinar in collaboration with the Association Québécoise de la Douleur Chronique, the Quebec Pain Research Network, and the Canadian Chronic Pain Network, which is funded by CIHR. We want to thank all the study participants who completed our survey, the Pain BC team, Maria Spit, Greg Moore, Catherine Sutton, along with Jennifer, our moderator today, our patient partners, our collaborators, and our research assistant. The first presentation will be made by Anaïs Lacasse, who is an associate professor in the Department of Health Sciences at the Université du Québec en Abitibi-Témiscamingue in Quebec. And she will be followed by Gabrielle Pagé, who is a clinical psychologist at the Allen Edward Pain Management Unit of the McGill University Health Center. And she is also an assistant professor in the Department of Anesthesiology and Pain Medicine at the University of Montreal, and a full-time researcher at the Research Center of the Centre Hospitalier de l'Université de Montréal. Finally, the last one, and not the least one, is Lise Dassieu, who is a health psychologist and a senior postdoctoral researcher at the Research Center of the Centre Hospitalier de l'Université de Montréal. And our moderator will be Jennifer Ensign, who is the Director of Education at Pain BC, and she leads the organization Education Initiative and oversees the work to catalyze change and build capacity among patient and provider in the Pain BC community. So I will, we have no conflict of interest to declare, and I will leave the microphone to Dr. Lacasse.
Thank you very much, Manon. Good afternoon, everybody. So we will look at the impact of the pandemic on the pharmacological, physical, and psychological treatment of pain. So why we did this study, as you may know, multimodal treatment is recognized as the optimal paradigm for the management of chronic pain, and a careful balance between medication, physical approaches such as exercise, or psychological approaches is very important, but it can be hard to achieve, and when it's achieved, can be easily disrupted. So even at the beginning of the pandemic, significant impact was expected. Notably, there was the reduced access to prescribers. There was a challenge surrounding access or use of many type of drugs, such as anti-inflammatory drugs, opioids, some drugs in arthritis management. So there was challenge there. Also, reduce access to many other type of treatments, the pain clinic, physical therapy, massage therapy, self-help groups, psychological counseling. So I could name many of them. Fear of going to healthcare appointments was reported among clinics, and also self-medication patterns. So even if all these disruption in treatment of pain were expected, it's important to quantify the impact of the pandemic, to have numbers to be more convincing when we want a new intervention and resources. So our objective was to document the impact of the COVID-19 pandemic on the pharmacological, physical, and psychological treatment of chronic pain. So as for our methodology, my part, I will focus on the web-based survey. The survey was done in the context of the COVID chronic pain and COVID pan-Canadian study. So we use many methods. Other methods will be presented by my colleague today. But for the web-based survey, people could answer to questions on their computer, iPhones. Participants that were invited were those who suffered from pain for more than 3 months, who were aged over 18 years old and living in Canada. So we use a web-based strategy. We put in place partnership with many associations such as Pain BC and IQDC in Quebec, which accepted to broadcast our invitation. We use social media such as Facebook, emails, a website. There was a draw of a prepaid Visa card to enhance the participation. And also the project had all ethical approvals, and our patient partner were involved in every step of the study from the beginning. So the survey was opened between April 16 and May 31. So it was, as you can see on the screen, it's the gray shaded area here. And it was at the same time when the cumulative case of the first COVID-19 pandemic were growing exponentially, notably in the Quebec province, in Ontario and Alberta, it was like growing. And also it was at the same time as the peak of daily new cases in Canada. So we captured the beginning of the first wave of the pandemic with the survey. So for change in pain treatment, participants were asked about pharmacological treatment and non-pharmacological treatment. So if they reported that their treatment had changed since the beginning of the pandemic, we asked why, so to collect all the reasons. So we analyzed this to create codes and to be able to prioritize which were the most commonly reported reason for change in treatment. So as for our participants, they came from almost every province and territories in Canada. The most represented province were BC, Ontario, and Quebec. So we were able to reach over 3,000 participants. Thank you very much for your participation. So most of our participants were females with a mean age of 50 years, and a majority, about half of our participants had pain for more than 10 years. So when we are looking at those who used drugs or medication before the pandemic, so almost 4 out of 10 reported change in their pharmacological treatment since the beginning of the pandemic. But if we are interested in those who changed their treatment because of the pandemic, it was 15%. Most frequent reasons were change in pain symptoms, lack of access to prescribers, including cancellation of medical appointments, and also many participants reported an increase in medication intake to compensate for the stop of physical and pharmacological approaches. So as for physical and psychological approaches, it was the type of treatment that were the most affected by the pandemic. So almost 6 out of 10 participants reported that they had to change their treatment because of the pandemic. So all the reasons were analyzed, and it was a big proportion of them who experienced such change. Lack of access to clinics, and also need to change the treatment in compensation for the change of another treatment were commonly reported reason by participants. So unfortunately, some patients had to reintroduce or increase their opioids in spite of tapering off before the pandemic. And also some reported using more cannabis, medical or not. or even alcohol to ease their pain because of the COVID-19 pandemic. We were interested in factors associated with change in the pain treatments. For example, on the screen you have the proportion of participants who change their physical and psychological treatment. We can see that it changed across Canadian provinces. And what is surprising is it's in Quebec where people had to change less their treatment, but it's there that it was the pandemic was the most important and the most affected province in Canada. So there was many other factors that were associated with change in pain treatments. I will not explain every factors, but just to name a few. For example, the type of clinic where patients received their pain treatment had an impact. The province of residence, as I show you, the type of pain that was suffering the participant, also being a female or being younger, were socio-demographic factors that increase the likelihood of reporting change in pain treatments. So to our knowledge, the present Canadian study is the first of its kind to quantify the impact of the pandemic on the treatment of chronic pain. I think the study highlights the significant impact of the pandemic on the treatment, and it probably continues to go. The impact was especially for non-pharmacological treatment, which are often hard to implement. So it's unfortunate at this level. The fact that fewer patients were impacted in terms of pharmacological treatment, so medication, it's maybe that effective measures were put in place for many patients. For example, deliveries from pharmacy, telemedicine, prescription prolongation. So there was various solutions that were put in place for the pharmacological treatment. So the priority is surely to maintain continuity of care for people living with chronic pain. So rapid introduction of virtual care should be implemented, but also when we are looking at our results, we suggest that short video should be available on the web, on social media, to explain and to give tips to people. So when the usual physical and psychological treatment is not feasible, what can we do? So it's one of the recommendations. So I will pass the control of the screen to my colleague, Gabrielle.
Thank you very much, Anaïs. So my part of the presentation will focus on pain status, so the evolution of pain at the beginning of the pandemic and psychological distress. Let me just see with the slides. There you go. So we know that there is a strong association between chronic pain and mental health. And this is true regardless of which population you focus on. So for example, if you look at individuals who live with chronic pain, typically we find higher rates of mental health, such as anxiety or depression or post-traumatic stress, than the general population. But the same is true if we go look at individuals with depression or with anxiety. They also tend to report higher rates of chronic pain compared to the general population. So in the context of a global pandemic, we can imagine easily how both pain and mental health can be affected. And so we wanted to document what was happening for individuals living with chronic pain in terms of those two aspects. If we go back at the beginning when we conceived that study was in March when things had started in Canada, and already we had a few research studies being published mainly from China or Asian countries who had been impacted a few months earlier than us. And already we could see that the pandemic had negative impacts in terms of anxiety and depressive symptoms. But most of the studies were conducted either on the general population or among healthcare providers. So we knew very little about more vulnerable populations, such as individuals who have health conditions. There's many hypotheses we had in terms of how the pandemic could be impacting pain and mental health. So obviously the threat of the virus, you know, how your body would respond if you get infected with the virus, and the level of restrictions that were imposed by public health organizations could also influence stress levels. We know that stress and pain are also closely linked. So if stress levels are higher, one might anticipate that pain could be affected. And combined with potential treatment disruption like Anaïs disclosed. So all of these factors were examined in our study. So we really wanted to describe the experience of the COVID pandemic for individuals living with chronic pain by trying to identify factors that are associated with pain deterioration and psychological distress in the first wave of the pandemic. So as Anaïs mentioned, it was a survey that was administered across the country. And this is to show you, like in March, there was already differences across provinces in terms of how they were dealing with the pandemic. So Quebec was the first one to declare the state of emergency across Canada with a very low threshold of number of provincial cases it took to declare that state of emergency, followed by Prince Edward County and then the other provinces. And as the graph that Anaïs showed you, there was a lot of provincial differences in terms of the number of cases. But I just want to emphasize, now we are facing the second wave of the pandemic, and it's most likely impacting us in different ways. So I just want to take a second to put things back in context. When we did the study back in April and May, I don't know if you're like me, but in my case, I was like, okay, this is going to end very soon. A second wave, what are you talking about? I cannot go through a second wave of the pandemic, right? There was a lot of uncertainty. Everything was new. We didn't know much about the virus. So the psychological response we had at that time is likely very different from the one we're having now. So just to put the results into context. And unlike Anaïs' result, the way we approached this analysis was not necessarily in terms of provincial differences, but rather in terms of exposure to the virus. And this is linked with the stress hypothesis, right? Like we had hypothesized that individuals who are living in provinces with higher number of cases, and in this we included Quebec, Ontario, Alberta, would likely have a stronger stress response than those living in provinces or territory with very few cases. So this is how we divided the analyses. In terms of the two variables we were interested in, so pain, we had simply asked individuals to let us know how their pain had evolved since the beginning of the pandemic in terms of significantly worsened up to significantly improved. And there's actually 5% of the participants who said that their pain had improved since the beginning of the pandemic. In terms of mental health, we were looking at general symptoms of anxiety and depression, and we split individuals' responses in terms of clinical cutoffs we have for that scale. So either people presenting with low or mild symptoms compared to people presenting with moderate or severe symptoms. So this doesn't mean that they do have a diagnosis of anxiety or depression, simply that they present with some levels of psychological distress. So what did we find? Here I'm just showing you some demographic in terms of the age group. So the largest proportion of respondents were between the age of 40 and 69. So we know that people aged 75 years or older were told to stay home more so than younger people. And this age group is also the age group where most people tend to be working. So it could be impacted differently from the public health safety restriction measures as well. Pain location was broad, so we had about half of the sample who reported lower body pain, and then a few people reporting low back, hip pain, or generalized pain, so pain in different areas of the body. And for the most participants, pain had been present for 5 years or more, which is quite significant. We only had, well, not only, but there were 116 participants in the study at that time who had mentioned being infected with the COVID. More likely, if we would to do the study again, this rate would be higher. But at that time, we had about 4% of the sample, so we didn't do any analysis with that variable. And 3/4 of participants were living in hot zones, so in provinces with a higher number of cases. We found that 2/3 of participants reported that their pain had deteriorated since the beginning of the pandemic, and pain was typically of moderate to severe in terms of intensity. and that pain deterioration was not necessarily specific to pain intensity. It was a broad question, as I showed you before. So likely pain deterioration would mean in terms of its quality, of its intensity, of its location or frequency. It could englobe really different aspects of the pain experience. Then we're curious to see what are some of the characteristics of those individuals who did report a deterioration in their pain. So obviously changes to treatments, whether it's their medication or physiotherapy or psychology or self-management, was associated with pain deterioration. Given the nature of the study, we didn't ask participants those questions before the pandemic or after, so we don't have a baseline measure. We don't really know what came first, right? Is it that pain got worse and so they changed their treatment? Or for some people, it might be the opposite. They were forced to make changes in their treatment and that led to increased pain. We found that those who worked were also more likely to report worsened pain compared to those who were not working, either because they were on disability or were retired. We found that higher level of stress related to the pandemic itself was also increasing the likelihood of reporting worsened pain. And this was stronger than just global stress level, not specific to the pandemic, and also stronger than what we call the more objective stressors, like if you were living in a hot zone or not. This was not a factor that came out in the results. We also found that older age was actually a protective factor. So older people were less likely to report worsened pain. And surprisingly, having lost one's job was also a protective factor. So this might be because those individuals were no longer working. So maybe if it was a more physically intensive jobs, their body was catching a break, or it could be because they had more free time now to engage in self-management of their pain. So just those are some hypotheses that could explain these results. Now moving on to psychological distress, we had 43% of participants who showed moderate to severe levels of psychological distress, and this is higher than outside of a pandemic context. What we found is, unsurprisingly, those who reported higher levels of negative emotions about the pandemic, so those who reported feeling angry, sad, afraid in the context of the pandemic, were more likely to report psychological distress. In this case, it was overall stress, not stress specific to the pandemic, that was more associated with psychological distress. And what we call human-related stress, so those who were feeling more stressed about not being able to see loved ones during the pandemic, or being afraid that their loved ones would be infected by the virus. Again, age came out as a protective factor, so older people tended to have less chance of reporting higher levels of psychological distress. So in terms of conclusions, the study found that unfortunately many individuals living with chronic pain experience a worsening of their condition since the beginning of the pandemic. It was not everyone, however, like Lise will tell you about in a second. And psychological distress was also important in nearly half of those individuals. One key finding is really that perceived stress, more so than objective stress, like more so that if you were really living in an area with a lot of cases, it was rather your perception of the pandemic that seemed to influence the outcomes we measured. And this is important because you don't really have control over how many cases are in your city, but there's things we can do to help manage stress so it doesn't have such a big impact on pain and psychological distress. So this is, as I just said, some of those factors were modifiable, like stress levels. And in future waves of the pandemic or in other pandemic, I think we need to put emphasis on ensuring adequate treatment access, not only for pain, but aspects that are influencing the pain experience, such as stress and psychological distress, and to offer management for those aspects. So I will now leave it to Lise for the third part of this study.
Yes, thank you very much, Gabrielle. I will present the results of the qualitative component of this project, the component based on participants' interviews. In this project, we examined the impact of the pandemic on the overall daily living of people with chronic pain. So, can I? Yes. Okay, regarding the methods, the objective of the study was to understand the impacts of the pandemic from the perspective of people with chronic pain. We used in-depth online interviews with open-ended questions. For those who are not familiar with qualitative research, this is a bit different from the survey that my colleagues presented. Here, participants could answer whatever they wanted, and they had the opportunity to develop longer narratives. So the data were collected from May to August 2020. So it was during the process of reopening in most provinces. Interviews lasted between 43 and 113 minutes, with a mean duration of 68 minutes. And 4 members of the research team were involved in the analysis of data. We had 22 participants that were recruited among the respondents of the survey. Provinces, 6 provinces were represented, and these provinces were Quebec, Ontario, British Columbia, Alberta, Saskatchewan, and Nova Scotia. Participants were aged 21 to 82 years old, and there were 11 women, 7 men, and 2 non-binary persons. Their pain lasted 1 year to more than 10 years, and 7 lived in rural areas and 15 in urban areas. So I come to the results of this qualitative study. First, we examined the impact of the pandemic on participants' chronic pain condition. So several participants reported increased level of pain or new pain during the pandemic. They linked it to anxiety and reduced physical activity due to stay-at-home orders. Participants also reported negative impacts of lockdown on their self-management of pain, especially some participants were more focused on their pain due to inactivity. It is the case for the participant in this quote. He explains that being at home all day makes him focus on his pain, and he has no more distractions. Conversely, some other participants considered that they had more time for self-management of pain and self-management routines due to being at home and not having to work, for example. We also asked participants about the impact of the pandemic on their access to pain management services. So several participants reported limited or more difficult access to their usual pain management resources. So even when the access was possible, it was often more complex to obtain services or treatments, which could add an important burden for those people who already have the burden of chronic pain. So in this example, the participant explained that he spends more time to obtain his medication, and he does not understand why it affects people with chronic pain. So several participants were also reluctant to use services, for example, when they had to go to the hospital, especially those who felt vulnerable to the virus due to immunity issues. Several participants also felt dissatisfied with online consultations. They felt that it was more challenging to communicate with physicians online. And other participants found that online services were beneficial as they could have a consultation while staying at home, and this accommodated with their physical limitations. We also assessed the impact of the pandemic on participants' psychological well-being. I think it's an important finding in this study, as many participants reported increased psychological distress, and several even mentioned suicidal thought, especially during the peak of the first wave. The situation could be aggravated for those who were socially isolated, those who had socioeconomic challenges, and chronic pain intensity and pre-existing mental health condition could also worsen their psychological state. In this quote, this is a participant who mentions all these intermingling factors, including economic difficulties, mental health, and also the unavailability of resources that can sometimes worsen people's distress. Regarding the impact of the pandemic on social life, many participants felt that they were most socially isolated during the pandemic, especially older persons, but also this could also affect some younger participants. Several participants expressed the importance of effective support from their family, especially older persons. For example, we have a participant who explained that she kind of stole hugs from her grandchildren, and this physical contact was very important for her, so she felt a bit guilty for this. And finally, access to pain peer support groups, online groups, was very important for participants to decrease their sense of loneliness. And sometimes the availability of the groups was in itself a source of support, even if participants did not always attend the groups. So socioeconomic inequities, we assessed, we noticed that they were also present for people with chronic pain. Economic difficulty could have a negative impact on both psychological distress and physical pain. Younger participants and those living on disability pensions seem to be more affected by these financial issues, and this could also affect their access to health care. Here we have one participant who explained that they had difficulties accessing online services and purchasing the material to access these services, and disabled people often have to use debt or borrow money, according to these participants. Finally, we also asked participants if they had a positive outcome and some related positive outcomes of confinement measures. First, confinement was not a disruption for several of them. Some were already at home. Their lifestyle was more normalized, and they were better understood by other people. This is what these participants underlines in his quote. Remote work was also more adapted to chronic pain condition for some participants. They had less stress for managing pain at work. However, we noticed that not everyone reported positive aspects, and these were more frequent among participants with high socioeconomic status or those who were not socially isolated. And finally, we asked participants about their hopes and their expectations for the future. So they had many hopes for society, global society change, especially a slower way of life that was highlighted by many participants as more adapted to their chronic pain conditions. So they would like this lifestyle can continue after the pandemic, focusing on what is important, especially spending time with close relatives, reducing social injustice. Several participants were very empathetic with social justice issues, racism issues that were in the media during the pandemic's first wave, and the pandemic context kind of opened the door for new hopes for more social justice, I guess. They also expected some healthcare system improvement, especially the development of home care services and remote services for those with chronic pain, and a better recognizing of their vulnerabilities at physical and psychological level. So to conclude with this qualitative study, it's important to highlight that the psychological and social effects of the pandemic add up with previous physical, psychological, and social difficulties associated with pain. During the pandemic, people with chronic pain have increased need for psychological support and monitoring of mental health, especially for suicidal ideation. Socioeconomic inequities are reinforced in the pandemic context, and they are also detrimental to physical and mental health conditions. So targeted biopsychosocial interventions, that is including medical, psychological, and social components, could help to support this vulnerable population. So to conclude, I would like to invite participants in this webinar who have lived experience of chronic pain and who live in Quebec. We encourage you to join the Quebec Association of Chronic Pain, AQDC, who is doing incredible work to offer resources and support for persons with chronic pain in Quebec, and who is a partner in this study. Thank you very much.
Thank you for that terrific presentation. It was really interesting research, and I think certainly the part of PNBC that provides services to people living with pain. I think a lot of what you observed or in the research, I think we saw bear out in some of the work that we do. So it was really interesting. Thank you. The team would like to invite any people who are on the webinar who have lived with persistent pain through the pandemic to share their experiences or reactions to the research. You can put your comments in the chat, or you can put it in the Q&A, and I can share some of those more broadly. So we invite you to do that. If you have an experience you would like to share, please feel free. For anyone else, if you have questions for this wonderful research team, please put them in the Q&A. I know we have a couple of questions already. So maybe there's a very meaty question here in the chat. There's a number of questions from Julia. Let me see, the first one is around how are the interventions for chronic pain management being monitored? I guess is the first question. I don't know if everyone can see this. So maybe I'll tell you all of the questions and we can kind of go through them. So how are the interventions for chronic pain management being monitored? How are the more vulnerable, marginalized, and underserved populations captured in this research? How might opioid prescribing guidelines and regulations for clinicians complicate the ability of persons who use drugs to access psychological, physical, and especially pharmacological resources to manage chronic pain? Is that, who would like to take those questions, and where would you like to start?
I know for the social inequalities, maybe I will let Lise share her experience with her interviews. But for the opioid guidelines, there was a paper that underlined that patients who use opioids would be particularly affected by the pandemic because it's more difficult to adhere to follow the guidelines for a good management with opioids in the pandemic time. So they were identified in the literature as it's inequalities in terms of access to treatment and a good management of opioid drug therapy.
With regards to change in pharmacological and physical and psychological treatments, our results are based on self-report, on patient self-reports. And there is also another paper which has been published by Mary Lynch in the Canadian Journal of Pain, which describe all the activities in the pain clinic across Canada and to be reduced because of the pandemic.
Interesting. Maybe would you, Dr. Choinière, if you have the citation for that, maybe you could put it in the chat or send it to me and I can put it in the chat. Yeah.
Yes.
Thank you.
Maybe I can answer to the question about minorities and marginalized people. So in the quantitative study, we did not have the opportunity to focus on this population, but the qualitative study, in the recruitment, we ensure to have a diverse sample, including racial minorities and First Nation peoples. So we have data from different perspectives. Of course, the challenges are not always the same for people who are marginalized. I talked about socioeconomic inequities in the presentations, but there are also other systemic inequities that can act and have consequences for people with chronic pain, especially in access to healthcare. We did not focus especially on marginalized people in this study, but I know that there is another study that is ongoing in Ontario by the team of Professor Webster that is among marginalized people in chronic pain. So maybe it can be interesting if you're interested in this population particularly. I don't know what to say else.
No, thank you. Could you maybe remind us how you recruited for the qualitative interviews?
Yeah. So we choose. We wanted to have a very diverse sample with many provinces represented, many situations represented. So we wanted to have young participants, old participants, and also half of the sample is from racial minorities. I didn't say it in the slide. I forgot to mention it, but it was really important for us. So we have 5 participants from First Nations, so from different provinces. So we can document these inequities perfectly.
And to actually recruit those folks, like you put out a call across social media, or how did you do it?
Yeah, so we sent emails with invitations for participants, and then we called them on the phone to schedule an appointment. They were free to refuse or to accept to participate.
Thank you. Okay, that's helpful. Does anyone want to add anything? Anything else to that body of questions? And Julia, maybe you could let us know if your questions have been answered or if you have further questions. Panel, you're okay. All right. I think, let me see. Okay, sorry, I'm just reviewing the chat to see if there's any other questions. I don't think there are. And sorry, did someone?
Yeah, so if we had to put in place solution, what would be the most important for you? What helped during the pandemic? Or what could be done next? If you have ideas or share experience that what could help you to go through this pandemic, maybe we could harness our data to support concrete proposition to decision makers.
Yeah, so that, I mean, that's interesting. What are you you know, where many of us are in the second wave of the pandemic now, and so sort of, are we able to kind of marshal this resource or research to make any changes for folks, or what's your hope?
Well, just to mention, we are doing right now a second wave of this study. So we reached out to everyone who had answered in spring and said they consented for us to contact them again. And so we sent out a second wave of that survey to help us answer a little bit more some of the questions that pop up as we were analyzing the first results, and to see what's the evolution as the pandemic progresses. And now this will be interesting because we don't have the same pattern as the first wave in terms of the number of cases across the provinces, in terms of how the healthcare systems have been able to adapt or not adapt. So there will be a lot of other type of questions we will be able to answer with this data set. But I think in terms of the results, like, yes, there are issues during the pandemic that are in some ways reflecting larger issues that were already existing before the pandemic in terms of treatment access for chronic pain. And so I think we have to put those results of our pandemic study in the broader context of how chronic pain is typically managed and treated. And this is overlapping a little bit with the work of the Canadian Task Force, what we've been doing and the type of revendications they're trying to make for this population.
Yeah, it really feeds into that work, doesn't it? That's wonderful. Oh, okay. Someone has suggested more online depression and anxiety group Zoom sessions.
So at the pain clinic back in Montreal, this is something we had started to do. So we had in-person groups, psychotherapy at the clinic before the pandemic, and we turned them into virtual groups, and we are doing a qualitative study around it to see how the experience is in the virtual environment to receive treatment for depression and anxiety. So we hope to be able to share those findings soon, so that post-pandemic, those type of tools and therapies could continue to be available because it can reach more people in remote areas or those for whom it's difficult to, just commute to a downtown hospital. So that research is coming.
That's great. Yeah, I think, I observed a lot of adaptation and a lot of very quick adaptation by many organizations and practices and clinics to really, even without this research, to really sort of change and respond to the need that they could see people were expressing. So I know our organization tried to, we moved our support groups online, and you're saying yours did the same, and many others did the same. So hopefully those will continue with the intent of providing just greater access.
And I wonder if any experienced group session for those who did not have access to pain clinics. So was there option implemented in some provinces that, so even if the participants don't have access to a pain clinic or even a primary care physician, if there was like more general public options?
Right. Yeah. Did something come up, and did they actually get more or a different kind of service as a result? Yeah, that would be interesting.
There are also virtual peer support group. For example, in Quebec, the Quebec Association of Chronic Pain Patients offers these support groups, which are which are supported by peers, and and I think that, and they offer some on a provincial basis. Like yesterday, we presented the results of our study in the context of a virtual support group. And so you can have a greater access to more people in remote areas and so on and so on.
Yeah.
I've also just put in the chat, at the beginning of the pandemic, we put a resource list together that is on the website of the pain clinic back in Montreal. So some of those resources might be more specific to Quebec, but there are a lot, self-management for anxiety or depression or feel pain in the time of COVID. So for those interested, you can go have a look and see if you find anything interesting based on your needs.
Wonderful, thank you for that. And Dr. Choinière, thank you for the article as well. That's really helpful. And I will
sorry.
Go ahead.
The Canadian task force, pain task force, if you go on the website of the Canadian Pain Task Force, you just have to type Canadian Pain Task Force, and you will be on the web on their website, and they provide a comprehensive list of resources related to the impact of the pandemic on people who live with chronic pain. So this can be another resource that you can use to have more information about what is available for Canadians who live with chronic pain.
That's fabulous. Thank you. Thank you for that reminder. Appreciate it. Yes, and just a reminder to anyone who is living with pain, who is also living in BC, that we do have a lot of virtual services that they're always free. We have pain support and wellness groups. We have phone coaching. We have our pain support line, which is a resource connection service. And you can call us or visit us online anytime to access those, and we can help connect you with resources in your area. So
people who live in British Columbia and who have chronic pain are very lucky to have Pain BC services. You are doing such a great job. And I think that all the provinces in Canada should offer the same type of services.
Thank you very much. That's a very nice compliment. Thanks. Well, listen, we're at time, so I just want to thank you all again for being with us today. Thanks for all the participants. Thanks for everyone living with pain who made the time to come. And thanks to the 4 of you. We so appreciate it. The research is fascinating and very needed during this time. And we look forward to hearing about the next cycle of it.
Thank you very much for the invitation. It was really a pleasure to share our results with you.
Thank you.
Thank
Thanks,
you.
everyone.
Thank you.
Bye-bye.